Welcome to the EAU podcasts. In this episode, UROONCO RCC Associate Editor Dr. Kuusk talked to Professor Axel Bex and Associate Professor Saeed Dabestani on the 2025 update of the EAU Guidelines on renal cell carcinoma.
Good afternoon, my name is Teele Kuusk. I'm UROONCO Kidney Cancer co-editor, and I'm today very delighted to have esteemed kidney cancer experts with me, Professor Axel Bex and Associate Professor Saeed Dabestani, to talk about RCC Guidelines Update 2025. Thank you so much. To start with, so how did Keynote 564 overall survival data changed guidelines recommendations?
We debated it fairly extensively, but it's the only trial that has shown overall survival benefit. You may remember that in the beginning we gave a weak recommendation, and the trial results were not so much different actually from the previous ASTRAC study. But the reason why we gave a weak recommendation was because there was an early overall survival signal. At that time it wasn't statistically significant, but then when the significance came in, we decided to change the update and give the recommendation as a strong recommendation. There was some debate because there is overtreatment, there is toxicity with it, but eventually we decided to do that.
And what about the treatment after adjuvant therapy?
I think that is a very good question. So first of all, there's very little evidence out there. The evidence we have currently comes from 2 randomized controlled trials in the metastatic setting. So they have shown that re-exposing patients to immune checkpoint inhibitors while they failed on, or the disease failed on immune checkpoint inhibitors is not a good idea. These trials were negative. So we're talking about CONTACT and TiNivo that investigated either atezolizumab following previous immune checkpoint inhibition or a combination of tivozanib and nivolumab. And that is one of the reasons why we now argue that if patients fail with their therapy on pembrolizumab, either during the treatment or 6 months after they stopped, that it would be ill-advised to continue with standard immune checkpoint inhibition in first line.
And now moving on to another exciting topic, stereotactic radiotherapy. What are guidelines recommendations in 2025 for local kidney cancer about SBRT?
That is a very interesting topic. So we had the publication of the fast-track trial, and I think it would be unfair to ignore these data. They have been done in a prospective fashion. It was a prospective single-arm study, but they included patients who were either not wanting to have surgery or were too frail, which was the majority, and they went up to 7 centimeters in size. And these are data which come from prospective evaluation. We should remind ourselves that cryotherapy or ablation was introduced without these tests. I think the downside of that study is, and it was extensively discussed before, also at the guidelines, is that the long-term observation period is rather short, but they had a 1 year, 100% tumor control rate. We therefore decided in the guidelines to recommend it for patients who are exactly following the eligibility criteria for fast track. So those ones who would be too old and frail and have a growing tumor, despite the fact that their life may be more limited, but this may lead to problems. And I think this is a good option that we included that in the guidelines.
And moving on now to surgery, Saeed, what are the recommendations currently for open and robotic partial nephrectomy?
So the guidelines has updated the text about open or robotic assist partial. We know that there's a large French trial since before showing that there are better perioperative outcomes and less morbidity in the robotic arm. And there are 2 randomized trials, the OPERA trial and the ROBOCOP trial that came out recently. The OPERA trial was a German trial that was cut short because they didn't recruit enough for the study analysis, but in the data that they had, they showed no difference between the 2 techniques. The ROBOCOP study, however, showed that there is a favor towards robot-assisted partial nephrectomy. With that said, the guideline recommendations still remain. We cannot give strong recommendations for robotic-assisted partial nephrectomy alone. I think does take into consideration that robotic assisted surgery is not available at every site across Europe. And it's important to kind of take all of the surgeon's aspects into this.
And what about surgical margin? Are there any news about positive margins and follow-up?
The latest publications that we know of, they show that there's a between 2 and 8% of recurrence risk if you have a positive surgical margin. Where what we have seen is that there is a higher recurrence rate in the literature. However, it shouldn't automatically warrant that you offer patients further surgical treatment. However, you should offer them a more tighter schedule of follow-up, so more frequent follow-up imaging. The positive margin does not automatically mean a poorer survival outcome, is kind of the takeaway.
And what about on and off clamp techniques?
Okay, thank you. So going back to the techniques, so there was a new publication, the CLOCK randomized controlled trial, which looked at off and on clamp during a partial nephrectomy. They did show that there was favorable outcomes with off clamp surgery. However, of the off clamp surgeries that were performed, 40% of them were converted to on clamp during the procedure. So from a guidelines perspective, we do still believe that on clamp is the standard of care still. With that said, there are nuances, and on an individual basis, not on a group level, there are certain circumstances where off clamp is mandated. And that is a surgical decision that needs to be made by the individual surgeon.
And now moving on to systemic therapy. Are there any new recommendations for papillary type metastatic kidney cancer?
Yes, they are. We had the presentation of the Sunny Forecast study last year at ESMO. That is an interesting study which was done for non-clear cell, but it included again papillary subtype. And the primary endpoint was well chosen. It was because you have a small study population, so you need to have a readout that goes probably a little bit beyond the standard oncological markers. And they were investigating the 1-year overall survival rate. And that was improved by using a combination of ipi/nivo in comparison to sunitinib. So that is one of the reasons why we discussed in the guidelines we already had cabozantinib for papillary renal tumors, but based on the keynote B61, we also had a recommendation for pembrolizumab, and there was another study that investigated nivolumab and cabozantinib. So I think we could add to this now ipi/nivo. The data in this subgroup are rather weak. That is also why we give a weak recommendation. But you always have to assess a trial from its primary endpoint, and papillary tumors were included in this study.
And where do we currently set belzutifan in systemic treatment paradigm?
Belzutifan was investigated as a further line study. If you look at the eligibility criteria for this trial, which was one of the LIGHTSPARK trials and was compared to everolimus, then patients were allowed in if they had at least 2, but up to 4 prior treatments. So it's a bit debatable, and that was also the criticism of that trial, that it has been, that belzutifan has been compared to the weakest kid on the block. I would say everolimus is not, has not been shown to be the best second-line therapy in the past. But we believe in the guideline, as long as further lines are being treated, then this should be available as an option. And that is why we added this to treatment recommendations. So I don't think it's the ideal second line, although patients were included with only 2 further lines or 1 previous line. But it is certainly good that we included that in the guidelines.
And last but not the least, what are your current research topics, and when could we have your updates and news and practice change from your research?
So liquid biomarkers for kidney cancer recurrence is my main focus, specifically clear cell RCC. I hope to have some results to present, which we're presenting on Monday, actually, here at the Game Changer session. I cannot divulge more than that because I've been put on embargo. But that's the main topic right now for me.
And for me, it's perioperative therapy, has been in the last 2 decades. But I find it very interesting what we can learn from other tumor types. So melanoma is the role model, I guess. And they have clearly shown that treating patients neoadjuvantly even allows to reduce adjuvant therapy after the tumor has been removed. And it was also better than event-free survival was compared to adjuvant therapy. And there may be a good reason for that, because when we did adjuvant studies, a lot of patients were not passing eligibility. So from baseline to their reassessment scan within 90 days, they already had small nodules appearing. So I think the most rapidly progressing patients are not being offered a chance for therapy, and that could be delivered by neoadjuvant. But because this is a guideline interview, we're not there yet, but I hope that maybe in 5 to 6 years' time we are there.
Thank you very much. Thank you for joining, and have a great meeting.
Thank you.
Thank you.
Thank you for listening to this episode of EAU Podcast. To keep up to date with kidney cancer developments, visit our educational platform, UROONCO Kidney Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.